Well, number one, we have to keep looking, because you never know. I think we also have to be a little more careful about selecting our patients for these studies. There may be a subpopulation of Alzheimer's that responds to an anti-amyloid, and I know there are a number of studies either starting very early, even before symptoms, maybe certain familial forms, maybe people with certain risk genes, much like we saw with cancer, that people with specific types of cancer, specific subtypes of breast cancer, for example, might respond better to therapies. And so I think we need to characterize our patients a little bit better in the long run to just and figure out who's going to respond, say, to an anti-amyloid or an anti-tau or an anti-Lewy body therapy of some sort. The other is, I remember one patient I had with Parkinson's years ago who said, I always wanted a cure, but had such a nice response to therapy that he said, you know, I don't need a cure if I can be this good forever, you know. And I think medicine's full of that kind of example. We rarely cure diabetes, but we do really help people out. And I think that's a reasonable starting goal. I think the field has been fairly reasonable, and we hope that we could, right off the bat, treat people who are already symptomatic. I think the familial studies, looking at people who carry the presenilin mutations, people who are ApoE4 positive and have amyloid deposition, are reasonable next steps, as are studies focused on tau and hopefully synuclein and Lewy bodies down the line. Many people are unaware that Lewy bodies are present in probably about 50% of people with Alzheimer's if you use the right techniques and look in the right area. And so I think we need to be a little bit more nuanced in characterizing patients, and especially in older patients, 75, 80 and older, it's often mixed pathologies. So things like good cardiovascular, cerebrovascular care can make a big difference in people's long-term outcome.